It's working. Oh no. Okay. As the previous speaker already pointed out, and as we know for about 2 decades now, is that there's consensus that non-emergency endotracheal intubation should always be performed with the use of pre-medication. But almost 20 years later, we do still not know which pre-medication strategy is most effective and most safe. Propofol is considered one of the acceptable options, and because of its easy in use and its fast-acting properties, it has become one of the favorable drugs, at least in Dutch neonatal units, but probably also in other European countries. I would like to hear from you about that. And there have been studies about Propofol, the effects and the side effects as well. And to our opinion, these data show conflicting and also some concerning effects, mainly on blood pressure of Propofol. And to further analyze the effects that different Propofol doses have on blood pressure in neonates, we performed this study. And we would like to provide guidelines for clinical practice with the information that we gathered. Wrong slide. For this current analysis, patients who participated in a previous NeoProp-2 trial were eligible. And the NeoProp-2 trial was a prospective multi-center dose-finding trial that we performed and recently finished, in which we included neonates with a postnatal age less than 28 days who needed non-emergency endotracheal intubation. They were stratified into 8 different age groups based on their postnatal and gestational age. And in each of the 8 age groups, we performed a dose finding using a step-up and step-down model that was based on the sedative effects and the side effects in 5 consecutive patients per group. So what we basically did, in every of the 8 groups, we started with a single dose of Propofol of 1.0 milligrams per kilogram, and based on the sedative effect and side effects in 5 consecutive patients, we increased or decreased the dose for the next 5 patients, with the aim of finding the optimal single Propofol dose that was the dose providing effective sedation with the least of side effects. And it's probably good to mention that I mentioned the single dose, but if that did not achieve sufficient sedation, then we gave extra before we proceeded with intubation. And regardless of the group that our infants were in the initial study, if they received a dose of 1.0, 1.5, or 2.0 milligrams per kilogram, they were included in this current analysis. Our primary outcome was the change in mean blood pressure over time compared to the mean blood pressure at baseline in the 3 groups. And our secondary outcomes were the incidence of hypotension, the timing at which the lowest mean blood pressure occurred, and of course also the sedative effect in the 3 groups. Blood pressure was measured invasively when an arterial catheter was present, and if that was not present, it was measured non-invasively. And we collected the data from 5 minutes before up to 60 minutes after the start of Propofol administration. Mean blood pressure, baseline mean blood pressure, that we defined as the mean blood pressure within 5 minutes before start of Propofol, and Propofol-induced hypotension was the mean blood pressure below postmenstrual age at the first hour after the Propofol start. Now I'm going to present you the results. I would like to present you the results. Yeah, there they are. And I'm going to start with the patient characteristics in 3 groups. And this slide shows that the gestational age, birth weight, and male gender, and gender were not significantly different in the 3 groups, but the postnatal age was. This was significantly lower in the 2.0 milligrams per kilogram group, but that was due to the initial design of our dose-finding study. So this slide presents the primary outcome. That was the mean blood pressure change over time compared to baseline in the 3 groups. And we calculated this change by subtracting the baseline blood pressure from the blood pressure at some time point after Propofol. So for example, when the mean blood pressure was 40 and at some time point after Propofol it was 35, then the change was -5, and that's how it was plotted in this figure. And what this figure basically shows, and I hope at the back of the room the colors are also clear, is that in all 3 dosing groups, the blood pressure declined in relation to baseline, and that this decline was not restored after 1 hour after the start of Propofol. And what this figure also shows is that the decline was dose dependent, so it was most pronounced in the highest starting dose of 2.0 milligrams per kilogram. As you can imagine, there can be factors that could influence the course of the blood pressure in this first hour. For example, the administration of volume resuscitation in case of hypotension, and also the administration of extra propofol. So we also did analysis with a correction for these two factors, but that did not change the results. Then I proceed to the secondary outcomes. First, the outcomes regarding blood pressure. This slide shows that the incidence of hypotension was high in all three groups and not different between the three groups. And although in 75% of the patients with hypotension in the 2.0 group, they were treated with volume resuscitation compared to less than 50% in the other two groups, this was not statistically significant. What was significant was the timing. In the 1.0 group, the lowest mean blood pressure occurred significantly earlier, at about 18 minutes, compared to the 2.0 group, at which it occurred at about 28 minutes. So finally, the results regarding effective sedation. And what this table shows is that in the 1.0 and 1.5 milligram per kilogram groups, that specific dose did not provide effective sedation in almost every patient. And that led to a high incidence of the need for extra propofol and also to a higher cumulative dose of propofol. On the contrary, in the 2.0 milligrams per kilogram group, the single dose led to effective sedation in over 85% of patients, and therefore this led to a significantly lower need for extra propofol and also to a very much lower need or lower cumulative dose of propofol. So in summary, propofol in this study, the starting dose of 2.0 milligrams per kilogram provided the best sedative effect, but also has the greatest influence on blood pressure. Not regarding to the incidence of hypotension, because that was high in all three groups, but not different, but with regard to the decline in blood pressure compared to baseline, which was most pronounced in the 2.0 group. And unfortunately, we do not have data on the cerebral effects of changes in blood pressure because we did in this study not use NIRS or amplitude integrated EEG. So in conclusion, this result showed a high incidence of hypotension and also a dose-dependent decline in blood pressure, which was dependent on the starting dose of propofol much more than it was dependent on the cumulative dose. And as we know, hypotension can have serious adverse events in neonates, but it is stated in previous reports that when hypotension was not accompanied with signs of impaired organ perfusion, that it could be stated permissive. And although it's reassuring that a recent report showed that cerebral autoregulation remained stable during episodes of propofol-induced hypotension, we think that we do not really know what the effects of propofol-induced hypotension are, not on the short term and on the long term. That's not fully understood, and therefore it might be by far not as permissive as we now think. So I think it's at least reasonable to be cautious with the use of propofol in neonates and to also consider other agents that have less effect on blood pressure. And when using propofol, then I think that starting low and titrating until effective sedation is reached seems the safest strategy. So I would like to thank my collaborators, my colleagues for collaborating with me in this study and also in the previous dose finding study, and I would like to thank you for your attention.